Hi everybody, Katy Lees, Principal 340B Compliance Advisor with Virtue 340B. Welcome back to Katy's 340B Compass. Today I was gonna, take a step back and let's go back to our roots of, 340B compliance. It's been such a crazy year. I mean, coming off of what we felt like was a crazy 2025, 2026 has just brought it to a new level. Everything is just flying at us. We're having to evaluate new policies, what's, going into place, what might be going into place, what's happening in the courts, and, just having to be very reactive, just so much to understand how is this going to impact our program. But, if we just take a step back, the key thing is we need to make sure that we know our programs. Think about what we can control and what we need to control, what we need to understand, be monitoring, just to make sure that, each covered entity is, performing to optimize the program, to understand the impact of all of these changes, but also just to be a good steward in the program. Each covered entity can do their part to support the integrity of the program. Make sure that you know how you're defining a patient, where you're using 340B drugs, how you're handling your offsite department, certainly something that continues to evolve, but an important element that still goes back to that patient definition, how you're preventing duplicate discounts. If you're in the hospital space, we're going to be coming up on recertification soon, for different, what I'm going to say today isn't even necessarily specific to hospitals. But, just these key things that when you're managing a 340B program, what you can control, where you can be proactive. That's what I just wanted to touch on today. Some of these thoughts, or maybe all of these thoughts, came from Eddie and I recently had the opportunity to lead a webinar with Haney's, the Hospital Association of New York State. We've been able to partner with them. They're helping us with some marketing, and with that comes some webinars where we're able to provide education, which, as you know, is something we're so passionate about, is just, educating covered entities, helping them maintain compliance, and just really understand their programs. So, I already, touched on my agenda. Just some of the questions that, we talk through to know your program, like how is your patient definition being applied across sites? Like, is your eligible prescription logic documented and defensible? Like, can you trace each 340B claim back to an eligible patient encounter? Do you have full awareness of your duplicate discount risk? Or even can you speak to how you're preventing duplicate discounts? Are your Medicaid numbers all up to date on OPACE? It varies by state. I think there's very few states that actually rely on that Medicaid exclusion file and your HRSA registration, but that's still a requirement. We still need to ensure that everything is accurate and up to date there. And even, what's your maximum fair price rebate exposure on both sides? So on, the duplicate discounts, and then this isn't really compliance related, but your exposure and the rebates maybe that are getting denied because of this. That's not something I'm going to touch on really in any detail today, but that is a very important element of understanding your program, is certainly understanding how maximum fair price is currently impacting your program, because it's only set to grow. When you're qualifying patients and prescriptions, think about, okay, have you defined how you're doing this in your policy? That's going to be probably more at like a high level. What is the time frame for a patient to have an encounter for that to be considered like a qualifying event? How are these rules being configured with your vendors? So if you're a covered entity that has contract pharmacy arrangements, you probably have more than one vendor even. So how are these rules that you've defined in your policy being applied in reality? Like, if you have said that, okay, an eligible patient has to have an encounter at a qualifying location within the past 24 months. How are you ensuring that happens, or how is that translated into your software to make sure that that's how it's approving things? Usually that's not, it can be, but usually that's not the only way that prescriptions are being qualified, but it certainly can be a key part of it, in making sure that you're qualifying patients appropriately? And then, are you testing these results? Are you testing to make sure that your softwares are only qualifying prescriptions based on how you've defined it in your policy? And when we talk about offsite departments, this has been an evolving element of the program, right? Like, depending when you're watching this, it may change even from today when I'm recording it. We've for years had to have a offsite department registered as a child site with HRSA before it's eligible for 340B. And then that was recently challenged, and the courts agreed with Albany Med, which is the organization that challenged HRSA on that, to say that no, HRSA doesn't have the right to say that an offsite department has to be registered as a child site before it can be considered 340B eligible. They can certainly require that registration as just part of the process, and it certainly aids in transparency, but that doesn't have to be a prerequisite to eligibility. So maybe some covered entities have changed their process based on that. And whether you are, however you're considering the offsite departments when they become 340B eligible, do you have that defined in policy? And are you applying that in practice? These are all very important elements of making sure that you understand and control your 340B program. When you're out there doing your advocacy and, just feeling fired up, as many of us are on a daily basis, about everything that's going on around us and the attacks on the program, like, it's very important that we can defend it, that every organization can defend their 340B program. And these are key elements to that. One thing that I find super helpful, and something that we've been able to help a lot of covered entities with at Virtue 340B is, setting up a tracking document for your offsite departments. And this same tracking document can not only be your everyday reference for what departments are eligible and not, but also the support when, you're audited by HRSA, so that you have, what they consider this crosswalk document that's going to crosswalk the departments from child site registrations to, what that department is labeled in your medical record system, how it's reflected in your financial system, and so ultimately how it rolls up to your cost report. And even if you're not, necessarily tightly following those child site registration rules anymore for eligibility, again, I would highly recommend that you still follow that registration process, but potentially an organization may make the decision that an offsite department can be eligible for that. I would still include all of these sites in this tracking document, so that, because if you're audited by HRSA, you have to be able to defend every location where you're utilizing 340B drug, whether it be drugs administered at that site or prescriptions prescribed that, downstream are being filled with 340B drug. It's very important that, you have this in place. And I think, whether it be a spreadsheet or if you have something more technically savvy to track all of these departments and to be able to prove which offsites are eligible, and why, that's essential in managing and understanding and being able to prove the eligibility of your program, and this should be part of that testing process too, going back to being able to trace prescriptions or, 340B transactions. That department is part of it. Where was the drug administered? Where was the patient seen? Even if it's a referral prescription, that care still needs to start with your organization and at an eligible site. So, this is a core element of your program in an area that is not easy. I'm definitely not going to say it's easy, but it's something that we can control, and we need to make sure that, we're managing it. And then, moving on to duplicate discounts. It's, as I said at the start, how are you preventing duplicate discounts in each setting? So in most of the time, Medicaid prescriptions and fee-for-service and managed care need to be carved out in the contract pharmacy space. So have you worked with your software vendors to make sure that that's happening? If you carve in for your in-house, whether it be administered drugs or contract or ambulatory pharmacy prescriptions, are you making sure that you understand the rules within your state of how you identify those 340B transactions for Medicaid. Is it that you put a modifier on it? And how does that work? It's very important to understand the rules in your state, to have those, how you're handling it defined in your policy, and then make sure that that policy is actually, being considered in practice in each setting. Because again, it does vary by setting of how you're handling it. And even if you carve in or carve out everywhere, how you achieve that probably looks different depending on the setting and depending on the software or whatever you're utilizing in each space. Another area where it gets challenging are out-of-state programs or out-of-state Medicaid programs. So that's just a whole other ball of trying to figure out. So you really have to think about, like, if you are capturing, just a couple out-of-state things here or there, or maybe you're near the border of a state and you capture a lot of things from that neighboring state and you're considering, carving in or carving out for your 340B program. It's very important to make sure that you understand those rules and that you know how your organization is handling it. I'll give an example. The state of Pennsylvania, their policy states that they reference the Medicaid exclusion file, but it also, their policy, which I'm not sure if it's stated very clearly, I haven't looked too recently, but last I knew it was not stated very clearly, that they only allow covered entities within the state of Pennsylvania to carve in. Any other state has to carve out. Even if you have a Medicaid billing number with the state of Pennsylvania, you cannot carve in Medicaid or carve in 340B transactions for them. It's unfortunate that the 340B rules vary greatly from state to state. A great resource is the Apexis website. They have where most states you can look and see what the rules are, and it gives you links and contacts for each state. So all important things to be considering. And then, as I said, we're going to be coming upon recertification time. It's an annual process. Every covered entity has to go through the recertification process with HRSA. If you do not recertify, then you will be excluded from the program. Your program will be terminated. So very important that you have OPACE up to date with your primary contacts and your authorizing official to make sure that you get all of the information and you have the opportunity to recertify. And then also, make sure that whether it happens right before recertification or maybe you take your time doing it throughout the year, but make sure all of your information is accurate on OPACE. So are your child sites all up to date with addresses? If there's any that are no longer open or if they've moved, like, have you updated those things? Are your Medicaid numbers on there accurately? Is your contract pharmacy information reflected accurately? It's easy to kind of get in this. Recertification is just busy work. It's a pain in the butt. I just have to go through and check the boxes, but you're attesting that you have a compliant program. This is our chance to really prove that, we are managing our program actively, that we're monitoring compliance, that we're updating things. HRSA a couple years ago made the change that you have to go in once for hospitals, but once your cost report's filed, you have to go in and update that information. That's something that used to happen at recertification time, but many covered entities may have to do that, prior to recertification now based on this new integrity process. But just let's make sure that we take the time to make sure everything's appropriate. The other thing, and I've mentioned this in a prior video, I like to use that crosswalk, that offsite department crosswalk, to really, on an annual basis, after the cost report's been filed, go through and make sure that all of those offsite departments still have the supporting costs and charges that were required as part of the registration. Make sure that they're maintaining that eligibility, so that, maybe you need to look into whether, if you can't identify costs and charges, one of those departments might need to be terminated. So also a really great exercise to do prior to recertification. So, I'm going to wrap it up here, I guess, but just hopefully this is helpful, like a few ideas that can make us feel like we're in control for a couple minutes. These are things that, we should really know about our program. And then, even just knowing this information as changes come out, it'll help you understand. I know that there's currently a challenge to HRSA's patient definition. It's important that we all know what they're asking for compared to, what each covered entity is practicing today, so that you can assess what the impact would be should we one day wake up and find that, something's changed because a court has ruled, in for or against that. I'd be surprised if a court is going to take a position on that, but nothing is off the table these days, right? So, I said this in my last video too, like the goal is not perfection. Like we just really need to do the best we can to understand our programs, having that clarity and having that control over these elements that, we can, it's key. It's probably help us, stay a little bit more sane on the day-to-day basis. But really important that we're understanding, how our organization is defining a patient, how we're handling our offsite methodology. Do we have documentation to make sure that we can back up both of those elements? How are we handling our Medicaid and our maximum fair price transactions to make sure that we're preventing duplicate discounts? And are we ready for a recertification? Because again, that's our time to prove that we are compliant and we're ready to prove it. So I hope this was helpful, and I hope you have a great day. Bye. Do you have a 340B compliance question? Send us a message at virtue340b.com. Thanks for tuning in, and we will see you on the next episode for more expert 340B advice. Talk to you soon.